My name is Michelle Wright, and I'm the Manager of Patient Support Initiatives at Lung Cancer Canada. And I am joined here today with my colleague, MG Sear. On behalf of Lung Cancer Canada, I would like to welcome each and every one of you here today and virtually for our Lung Cancer Patient Summit. I want to thank Dr. Stephanie Snow and Chelsea Green for all of their help in bringing this event to fruition. We're grateful for all the time and energy you put into making this a success. And I would also like to thank each of the speakers joining us and sharing valued information and their stories. So first, I would like to introduce Dr. Stephanie Snow. Dr. Snow has been a staff medical oncologist at the QE Tooth Hospital in Halifax, Nova Scotia since 2010, and is currently an associate professor at the Faculty of Medicine at Dalhousie. She completed her MD, internal medicine and medical oncology training at Dalhousie. She treats head, neck, thoracic, and GI malignancies. She oversees the Dalhousie Undergraduate Medical Oncology Program, and her research has been published in many journals. Finally, she's involved with patient advocacy, currently serving as a member of the Executive Committee of the Canadian Gastric Cancer Association, a medical advisor to My Gut Feeling, the Stomach Cancer Foundation of Canada, and president of Lung Cancer Canada. Welcome, Dr. Smith. I gotta go to the camera. Thank you, Michelle. And we have to put in the to-do list. It's time to update that bio. I think that one's about 10 years old. Oh, no, apologize at all. So thank you all for joining us here in this room here in King's College, and those of you who are joining us virtually. I'd again like to thank Michelle for organizing, making this happen. And I was horrified at the prices of the hotels for bookings. So Chelsea, my admin assistant extraordinaire, managed to find this room for us at Dalhousie. And then MJ, our great organizer. And for those of you who participated in the Give a Breath run last year and hopefully again this year, this will be a very familiar face. So hopefully we'll see you again in June 7th. So hopefully we've got some posters. I'm here right now as one of the speakers. And how long did we have our last Halifax summit? My goodness, long before COVID. I think it was way before COVID. Yeah, it was. And it's funny because at that point in time, I did a talk on new treatments for lung cancer. And I actually looked at, and there's a lot of updates to do for this talk here today. And I'll make sure I'm on time. You can yell at me if I'm going over time. But let's just start up here. So we're going to talk about some of the new treatments. And this is not like a scientific talk like I would give to medical students or other physicians or nursing. I really want to talk about some of the more innovative things that we're doing from a technological perspective and give you some examples of some of the trials that are really changing things and hopefully making it that you guys can see how excited we are as lung cancer treaters, how things are moving along. So in the 2023 Cancer Statistics Report, they did have a really positive statistic. We often talk about the negatives. We do know that lung cancer is the most common cause of cancer death among all Canadians, men and women, but sometimes it's nice to focus on the positive. And so in that report, there was this lovely little snippet that said lung cancer mortality is declining faster than any other cancer in Canada. And that's great. And at that point, it was a little bit more than 4%, the rate of decrease in mortality for both men and women. So why are we seeing those improvements? Well, there's a lot of different factors. Part of this is relative to the fact that we've seen more and more smoking cessation. And many patients, they don't use tobacco anymore, but they'll still develop lung cancer later. We know that's the top risk that we see right now among lung cancer patients. And so if you quit 20 years ago, you still might develop lung cancer. And so those decreasing tobacco use rates that we've seen over the past decades are now starting to translate into less patients being diagnosed and ultimately dying from their cancer. We're also thrilled that we're hopefully going to see even more bumps in screening and early detection. One would hope that we've already seen some benefit in British Columbia, which of course was the first province to roll out their screening. And of course, before that, we had pilot programs, including one that was run here in Nova Scotia through CPAC, who's been an amazing organization supporting lung cancer screening. But we officially launched our Nova Scotia program last year. And just this week, we had the formal announcement of the rollout in our eastern zone, which is incredible. incredibly important because we know that rates of lung cancer in Cape Breton are incredibly high, in large part related to different occupational exposures and also the demographics there. We have an older population. So very exciting screening and early detection, because when you find a lung cancer early, we do have a chance of actually curing that cancer. But a lot of it is those two bottom boxes here, better therapies. We have better therapies to treat cancers for cure. And we also have better treatments for those patients that we can't make the cancer go away forever, but we're helping them live their best life with lung cancer, having also the longest survival. And we have patients now with certain subsets of lung cancer who can survive with a stage 4 incurable, sometimes for 10 years or more. Or even with immunotherapy, I have patients who were diagnosed with stage 4 incurable lung cancer in 2013, and all their cancer disappeared with immunotherapy, and they're living their best life with no sign of cancer on their scans. I literally have goosebumps when I still talk about these patients, because it's such a change compared to when I started as a medical oncologist, and all I really had in my toolbox was chemotherapy. So let's take a look at some of these new treatment options and advances that have really changed how treatment looks for our patients. So starting off with surgery. A lot of my patients who had surgery for surgical resection of their lung cancer in the past, they have chronic nerve pain. It's very classic, it wraps around their chest wall. A lot of women can't tolerate to wear a bra. And that's because they did these really large incisions. And so this was actually the incision. You can see how many ribs are being cut through here. The ribs were being pulled open to give the surgeon access to the actual chest. And underneath each one of those ribs is a pack of nerves and blood vessels. So when those nerves are severed and stretched, you can end up with permanent damage. And so we've really come a long way also in terms of postoperative complications. Can you imagine a big incision like that? Much higher risk for things like an infection, harder to get up and walk around after your surgery, patients be in hospital for weeks. Now I see some patients having surgery and they go home the next day. They had part of their lung removed and they go home the next day. And that's just amazing. And so how are they doing this? Well, here in Halifax, as in most other centers, VATS, or video-assisted thoracic surgery, is now the standard of care. So our surgeons will put these little trocars, these metal tubes that go into the chest wall. One will hold a camera so they can get that view. For instance, right here, you see the trocar coming through the chest wall so they can see what they're doing. Another has a clamp and the other has the stapler. And they can do these surgeries just through these little holes. And sometimes the biggest incision is the hole they have to make to get the actual tumor out, because you don't want to chop that up inside the chest. There's even more advances happening now. Oh, there's a picture of what the different surgeries look like. So here you had the open. Let me see those ribs pulled apart versus our surgical team here looking at the video screen so they can see what's going on there. Now, even neater than that is robotic surgery. So in robotic surgery, you still gain access to the chest, so those trocars. But here you see the surgeon, he's not even at the, or she is not even at the, it's a he in this case, at the table. It's almost like they're playing a video game. And they're operating all these little robots, and it really allows for some very highly finessed technical skills. Now, we have some amazingly gifted surgeons in Canada. I've heard from the other thoracic surgeons tease them, are like, yeah, you can do that with your hands, but give me a robot and I can do that too. And so Alison, Wallace, who is one of our amazing thoracic surgeons, she's going to be speaking with us tonight about some of her research. She really wants a robot. And urology has a robot, but they're not sharing, is my understanding. So that is definitely on our wish list. But there's some major centers like in London, Ontario, that are really leading the way for a lot of these robotic surgery. So really going to be the wave of the future. Now, moving on to radiation. So radiation plays many different roles across all the stages of lung cancer. But in terms of early stage lung cancer, we can cure people with radiation alone. And that's really important because a lot of our patients with lung cancer are older. It's definitely a disease that can hit any age, but really it's more predominant in the older population. And especially if you have comorbidities, if you have a bad heart, bad lungs, and anesthetist just says, I don't think I can put you to sleep. Or the surgeon says, if I remove that part of your lung function that you'll be left with will not be conducive with quality of life. You'll be oxygen dependent. Sometimes, even though the tumor is resectable, it's not conducive for that patient's overall well-being. So with this really neat technology that goes way over my head because it's all math and physics, called SABR, which is stereoablative radiation. So our radiation oncologists can give a very large dose of radiation to a very small tumor and essentially ablate it and eradicate it. So when we do find these tumors in elderly patients or otherwise ill patients that are stage 1 and 2, but they just would not really be a candidate for surgery, sometimes they're not even a candidate for a safe biopsy. If we know it's cancer, it's growing, it lights up on a PET scan, they can do this, very well tolerated in most cases, and actually cure their lung cancer. Now, surgery does remain the standard of care, but the radoncs are always trying to push that boundary more and more. And I think we do a lot of this in Nova Scotia and across the board, and this has really added the chance to cure that didn't exist before this technology. Now, moving into, of course, my favorite aspect is the systemic therapy. And of course, I know more about this because as a medical oncologist, systemic therapy is what I use. And so really exciting things have happened since I started my practice. And all I had was that first box, chemotherapy. So I often kind of judge where we are in timelines and sense different technologies have come out based on my own personal history. I think of, I was young and I started, and then, I met my husband and then I had a baby. So the next one, immunotherapy checkpoint inhibitors, I associate that with my son. Because I went on mat leave in 2014. I made the best choice of my life. I took a full year off to be with my son. And when I came back in 2015, the whole landscape had changed. When I went off, I can remember sitting in huge lecture halls at World Lung Conference, having them just talk about these new therapies. They didn't even have names at that point. There were a series of letters and numbers. And these were immunotherapy checkpoint inhibitors. And they were just going into trials. But when I came out, they were actually accessible. And that's when I treated that lady I talked to you about, who I gave her immunotherapy, and all her cancer still remains gone today, including her unradiated brain mets. And so when I came back from mat leave, I had a whole new learning curve of learning immunotherapy. And at that point, we only had access for patients with non-small cell lung cancer. There was no role in small cell. And it was for patients who had progressed after standard chemotherapy. And a lot of patients after standard chemotherapy, they weren't well enough for further therapy. So we were having what we call an attrition rate. So since then, we've moved immunotherapy into the mainstay as the backbone of all our systemic therapy treatment options for patients who don't have a driver mutation for whom we have a targeted therapy. And now we've actually moved it into the curative intent setting. And so that's what we're going to talk a little bit about. And we're still pushing those boundaries of immunotherapy. We also have targeted therapy. Targeted therapy, actually, I should put that before immunotherapy because it became before. I still remember being a third-year medical student, and that was not yesterday, doing an elective at Princess Margaret Hospital, and one of the great teachers, Dr. Ron Burks, who's still teaching and treating lung cancer patients there at Mount Sinai Hospital, talked to us about these new drugs, these tyrosine kinase inhibitors, and how there's these new papers in the New England Journal of Medicine where if you gave them specifically to young female Asian women with lung cancer, their cancers would just melt. We didn't even know what EGFR was then. We figured it out afterwards, as we do many things in medicine, and we do know that that's a certain type of patient we're more likely to harbor one of those EGFR mutations. But now we know we can find an EGFR in anybody. We can find an old dude who used all the tobacco, and we can find in our young female non-smokers. And so it's very important that we learned how to use these drugs because they've really revolutionized. So we started with EGFR, and now we have a laundry list of targeted therapies, and we have multiple generations of targeted therapies for our different mutations, and that's really changed the landscape. Now, much more recently, things that have me struggling to figure out how I'm going to get these into our healthcare system, we now have these new drugs called antibody drug conjugates. And in this case, it's like a targeted therapy, an antibody had a baby with either a chemotherapy or an immunotherapy. So we're going to talk about those. And then we've got cellular therapies, which are a form of actually getting the immune system to work in a different way than immunotherapy checkpoint inhibitors. We're going to talk about some of those new therapies. So starting again in early stage, when we talk about early stage cancer that's resectable, I mean that the surgeon can safely remove that part of the lung. In the past, we would do surgery and they would offer 4 cycles of chemotherapy, and that was based on high dose cisplatin, and that on average would give our patients 5% increased chance of being alive at 5 years. We've really changed that landscape now because for those patients who don't have driver mutations, our standard of care has become induction therapy with immunotherapy and chemotherapy, then surgery, and then in many cases, more immunotherapy after that. And we now have multiple trials, phase 3 massive trials, which have compared chemotherapy and surgery to this new strategy of introducing immunotherapy. And what we're seeing is much better outcomes. So we're seeing patients living longer. So you're not supposed to be able to see all the details here, but we have 4 survival curves here from the 4 major trials. And in the survival curve, all the patients start off at the 100% mark after their surgery, at their point of diagnosis. And then as they kind of, those curves fall down, those are people who are either having a recurrence of their cancer, having a death event, or they're having something bad happen so they don't make it for surgery. And the top line in each one of these trials is the arm or the group in those trials that actually receive the immunotherapy. And we see as we go up, these are months along the bottom, we're now having 5-year data showing much better outcomes. Early separation of those curves, and those who are in the top arm and are doing much better, living cancer-free and hopefully cured of their cancer, they have a much better chance if you're in one of those top curves. And we know that the reduction of risk across the trials is between 30 and 40% on average. So really changing. This is what we do standard of care here in Nova Scotia and across the country now. We also know there is an option for patients who need to go for surgery up front, or there's some reason why we wouldn't want to give them upfront chemotherapy and immunotherapy. They can still have surgery, but it's not just chemotherapy afterwards. Now they can have immunotherapy afterwards and also still have a survival improvement, or if they are known to have one of those driver mutations, such as an EGFR or an ALK mutation, where we know that immunotherapy just doesn't work the same way that it does in our regular lung cancers that are often related to tobacco, they can now receive targeted therapy. So this is an example of a recent trial that read out in the ALK space. And here we see a comparison between post-surgical chemotherapy and those orange bars, red bars, compared to blue, which is the targeted therapy called alectinib. And here we see on the left-hand side, that is the rate at which patients are having relapse or recurrence of their cancer. And we see that that blue arm, alectinib, much higher numbers, meaning that they're remaining cancer-free compared to chemo. So much better effective therapy. And here we see protection in the brain. When we see recurrences and patients develop brain metastases, it can be quite devastating. Much more difficult to treat and a huge impact usually on quality of life. And we can see this is also protecting the brain from recurrence. It's something that chemotherapy hasn't done for us. So this is a new therapy that we're just starting to roll out and use in clinic for our ALK-positive patients who have surgeries. So in the future, there are so many new exciting possibilities, all those new therapies, all these combinations, and we're just trying to bring those bars up higher and higher and higher so that those who we are treating for cure with surgery will hopefully remain disease-free and long-term survivors. Now, this is just one example of some of the exciting things that we're doing. This is a trial that we're in the process of opening in Halifax. And this is a complicated schema. You don't have to understand and read all of that. But the bottom line is patients are treated with their upfront chemotherapy, in this case, standard cisplatin and pembrolizumab and immunotherapy. They go for surgery. If in that surgical resection specimen, there's still some viable alive cancer cells left, they take those cancer cells and they actually look to see what proteins are expressed in the cancer cells, and they make an individualized vaccination for that patient based on those proteins. So here the randomization is V940IM in the top arm, the experimental arm. That's the vaccination. Again, given with pembrolizumab, which makes sense because the vaccination is to turn on the immune system, the pembro is to keep it going and make sure it does its job, versus the placebo. So our patients in Nova Scotia are going to have access to this trial, which may be the wave of the future. And it makes so much sense. It's truly personalized medicine. So now moving into stage 3 lung cancer. Some cancers we can't cut out because they're too locally advanced, but they're still can be treated for cure with combinations of radiation and systemic therapies. And it was in the past, all we had was combined chemoradiation, and there weren't great long-term survival rates, but we were curing some people. What really changed us on the playing field here for stage 3 was not the newest, but is relatively new, was after chemoradiation, those patients who had not progressed getting a year of consolidation immunotherapy. And here we have updated results from that trial. The blue arm are those who got the immunotherapy for a year. These are survival rates. Out to 5 years versus those who got a placebo. And those who got the immunotherapy, we can see that there's about a 10% improvement in their likelihood of being alive at the 5-year mark. That means we've cured an extra 10% of patients with this stage of disease. But immunotherapy, as I mentioned, is not great for everybody. And we have a lot of patients who might have driver mutation driven, EGFR, ALK types of cancers. And we really struggle with that. Like, if I have an EGFR patient, am I going to offer them the immunotherapy? It may not work, but it can have side effects. And it can actually have implications downstream if they do have recurrence. The osimertinib, the targeted pill I want to put them on, that can cause a lot more side effects if they've been previously exposed to immunotherapy. So we kind of struggled and pulled our hair out, but now we don't have to anymore, because the current present is that now you can actually receive for EGFR positive cancer your targeted therapy after your chemo res. And we know that makes so much sense. And look at this survival curve. This is amazing. So these are patients who at the LAURA study that read out last year after chemo radiation. The orange arm are those who were immediately treated with osimertinib, generally a very well tolerated oral therapy, versus those who got a placebo. A huge benefit here for these patients. So really changing that playing field. Now moving on to stage 4. How am I doing for time? Very good. Okay. So stage 4, we've got so many evolving treatment options. I could do a 5-hour lecture on all the new things that we're doing in stage 4. And of course, we have different driver mutations and non-driver mutations and all kinds of different things that we can do. But what we're really focusing on novel combinations. So we say, what happens if we give chemo and immunotherapy together? What happens if we give chemotherapy and targeted therapy together? These tools that we already have, what happens if we put them together? There's also the novel therapies, as I mentioned. We're going to talk about some of those new fancy-dancy molecules, the antibody-drug conjugates, our bispecific antibodies, and also we're getting better tests. And so lung cancer is very heterogeneous when you look at it at a molecular level. So if you can't find the targets, you're just kind of guessing what the best treatment is, and you might miss out the best treatment for a patient. So the better test we have, and using things like AI, artificial intelligence, is really going to change the playing field for our biomarker tests as well. So these are some of these new fancy-dancy molecules I was talking about. So antibodies, our body makes antibodies. We make them to target bacterial proteins, viral proteins. When you get a vaccination, that's what it is. It's some dead protein from, for instance, influenza or COVID, with the goal of stimulating the immune system to ultimately make these antibodies. These antibodies go around, and the part of that kind of Y, the top of the Y, actually looks for specific antigens. That's our medical term for proteins that are unique to a bacteria or a cancer or any particular cell. And the end, the stick of the Y, that's kind of like a big flashing sign that says, hello, immune system, come here. I've marked this. But it also can block if the target of the antibody in the Y side is a receptor that needs to be stimulated, to be turned on to drive a cancer into growth. You can block it so that you can no longer get your key in the keyhole to unlock that door if it's jammed full of bubble gum, is the example I sometimes make with my patients. And so antibodies that we've typically made in the lab, and then we give intravenously to hit these different cancer targets that had one target. But now we've gotten really smart, and they've learned how to make 2 targets. So that's a bispecific activity. And this has really opened up our world in how many things we can target with a single therapy. We can hit 2 targets, things that we know there's 2 keys, 2 locks to open up that door. So you can block one, but if they go in through the other side, you're not really going to get that same benefit, but now we can block both. Or we can also use these, I call them as matchmakers. One can bind one cancer cell, one can drag that immunotherapy or that the cancer-killing T cell right on over. So I'm going to show you some examples of those, bringing them together so you really get that effect. Now, the antibody drug conjugates, this is chemotherapy grew up and got smart. Chemotherapy can be incredibly effective. At the end of the day, though, they're poisons. And I like to tell my patients the art of chemotherapy is me finding just that right dose so that I can get an effective kill of your cancer cells, but not do too much harm to your healthy cells, because that's where side effects come from. Antibody drug conjugates are smart because that little orange ball, that's the chemotherapy. But the drugs that are attached to antibody drug conjugates are super crazy potent compared to the typical chemotherapy we just give in a bag that goes throughout the body. Because if we try to give those super potent doses, we'd actually cause so much harm. We'll probably kill our patients from the damage to healthy cells. But by attaching it to an antibody and making that antibody go and seek out specifically cancer cells, you can selectively deliver the chemotherapy to the cancer cell and thereby spare, ideally, as many healthy cells as possible. And how many of these drugs work is when the antibody sticks to the cancer cell, has found its target, which hopefully is a target that's not expressed on healthy cells. This cancer cell just gobbles the whole thing up inside. Now the chemotherapy drug is inside the cell, That little gray bar called the linker breaks off, and now the chemo's inside the cell, and it didn't have a chance to cause other harm. But what do cancer cells live next door to? They live next door to other cancer cells. So even if a cancer cell doesn't have that specific target of the antibody, once that cancer cell is done, they can kind of move over and kill the next guy. But you're not going to go all throughout the body to hit the bone marrow and the kidneys and the liver and all those things. So very exciting drugs, these antibody drug conjugates. So here's some examples. So amivantamab. Amivantamab is a bispecific monoclonal antibody. And we know that for patients with advanced EGFR positive cancer, our oral tyrosine kinase inhibitors, things like osimertinib, are very effective. But eventually, the cancer becomes resistant. And it's because of these different pathways. So here we have a little schema, a cartoon of the cell wall. The blue is the EGFR, so you can see it's got the receptor on the outside of the cell. And then it's got a tail that goes right down into the cell, and that's where it sends up all those messages that ultimately go to the DNA, make the cell do things like grow and spread. Next door to that is MET. And MET goes into the same very pathway. So there are two doors to get into the same house. And we very commonly find that for patients who have EGFR positive cancer and they progress on something like a tyrosine kinase inhibitor like osimertinib, if you biopsy them, all of a sudden their cancer has tons of MET. The cancer cell upregulated and just put a big sign, everyone go to the back door. There's a back door over there, and they opened up all the new back doors. So amivantamab, you can see that little molecule up there, that Y, it hits both of them at the same time. So what we know is that amivantamab has activity after a drug like osimertinib, but more importantly, and just like a few weeks ago at the European Lung Cancer Conference, I wish I'd been there, it was in Paris, but I only get so much conference leave, and there's so many trials I'd like to read out, but this was the first line trial. So in this trial, the Mariposa trial, the gray arm, osimertinib, is our standard of care. The blue arm was giving a drug just like osimertinib. They're kind of like Coke and Pepsi, called lazertinib, but they add in the amivantamab from the beginning. And so you're blocking that resistance mechanism from ever even getting in there. And this is overall survival data. Here we see out at the 36-month mark, the 3-year mark, we're seeing about a 10% higher rate of patients being alive when they receive both drugs. Now there's extra side effects and there's logistics and it's an IV therapy. So these are conversations for us to have, but ultimately it's so amazing for us to have these types of new therapies in our toolbox. This is an example of a new smart biomarker. So there's a lot of cancer drug development based around this protein called TROP2. And it's not just in lung cancer, it's across many different cancers. And when you stain with a regular stain, the kind of stains that our lung cancer pathologists have been doing for decades, you take a slice of the tumor, you put it on a slide, you put the dye, you wash it off and see did the cancer cells pick it up. Almost all non-small cell lung cancers will actually show this TROP2. So when they developed a particular drug for TROP2, they could really give it to everybody. And they found it worked in second line, kind of worked. Was definitely better than docetaxel, which is our standard chemotherapy that we usually use in that setting, which does have a role, but we don't like giving docetaxel if we don't have to. But there were certain subsets that really seemed to benefit, and some subsets really didn't seem to benefit at all. So they went back to the lab and they said, how can we identify who these patients are? And what they learned is if they take a picture of that actual slide, so they do their regular staining, and then step number 2, they put it into a computer to take a picture. The computer can actually be super smart. It looks at every individual cancer cell on that slide, and it looks to see if the trope is on the membrane or the outside of the cell or also in the inside. And it calculates mathematically a ratio. Now, my pathologists are wonderful, but they're not going to do that. They don't think they're capable of doing that. Their eyes can't zoom in that small. And plus, they would probably kill me if I asked them to do that. Can you imagine trying to count every single cancer cell on a biopsy? But with this particular ratio that they calculate, they were able to clearly identify a group that was benefiting and those patients who would not benefit. So this is not a drug to waste your time and money and side effects on. And so here we have that data from a drug, an antibody drug conjugate that's targeting TROP2. So up here on the top, we see there's a monoclonal antibody that's very familiar now, that Y shape. Its target is TROP2, and we've got the linker, that big, long, complicated organic chemistry molecule. That's the chemotherapy. And here in the bottom, these are the results from the trial when they actually figured out the different groups based on the presence of this biomarker. So the top purple, that's the group that got the actual antibody drug conjugate and were positive for the biomarker. The three, what I call spaghetti string survival curves, which are doing pretty much the same, those are the ones that got the antibody drug conjugate, but they weren't positive for the biomarker. And that's the other two groups, positive or not positive, who got the chemotherapy, that docetaxel control. So now we clearly have identified a population. So as we move these into our practice, and if we have access to these therapies, we're going to be able to make a smart decision. And for those patients who are in the lower curve, we'll find out what's best for them. And we have to keep pushing these boundaries. So very exciting ways to do the biomarker plus an antibody drug conjugate. So small cell lung cancer. Small cell lung cancer is more rare. It's about 13% of our lung cancers in Canada now, but it can be a very devastating cancer. It's not something we're going to pick up with screening because once it starts to grow, it grows so quickly. It doesn't have a long indolent phase like many non-small cell lung cancers can, when you can pick them up before symptoms at a stage 1 or 2 and they're curable with surgery. Also, it's a very aggressive cancer. It's usually sensitive to chemotherapy when we first treat, but unfortunately, when it becomes resistant, both chemotherapies just don't work the same way. And we often find the patients have a much shorter survival than, for instance, their counterparts in non-small cell lung cancer. And we have tried so many studies for decades, and it's really only in the past 5 or 6 years that we've really changed things. One of the huge differences that we had the advent of immunotherapy in extensive stage lung cancer, and that's now our standard of care with chemotherapy. And for about 1 in 10 people, it makes a huge difference in how long they live, but that's 1 in 10. And so we're always trying to push that further. So here is limited stage small cell lung cancer. This is when the lung cancer small cell, it's pretty rare that we see this. It's definitely the minority, but the cancer hasn't spread to other parts of the body. We have a chance of curing them with chemoradiation. In the past, they got chemoradiation, and because chemo doesn't do a good job of cleaning up the brain, we would consider them for prophylactic or preventative brain radiation. They cross your fingers and follow them for 5 years, and if they made it 5 years, there's no sign of cancer, they got to celebrate and be discharged from oncology. Now in the present, we start off with combined chemoradiation. Oh, I should have had immunotherapy in there as well. I forgot the immunotherapy part. And no, that's a lot. That's advanced stage. Yes, I did do this right. Combined chemoradiation to start. Still consider your brain prophylaxis, and then 2 years of consolidation with immunotherapy. And in fact, just a few days ago, we had Health Canada approval for this regimen in Canada with durvalumab. And these are the survival curves for limited stage small cell. When they get that 2 years of durvalumab, we see we're again increasing that cure rate at the 3-year mark by about 10%. So pushing that bar ever higher. So this is an example of how we're curing people. And this is as hot and fresh off the press as you can get. It's just approved earlier this week. Finally, I want to give an example of another bispecific molecule, a drug called tarlatamab. And tarlatamab is a drug that has been recommended for funding in Canada, and it's not readily accessible right now through provincial funding, but there is an access program. And right now on my to-do list is to set up a tarlatamab program, which is not as simple a matter of, just writing an order set and booking some time in the chemotherapy unit, because especially the first few doses, patients can have a very significant immunotherapy response or immune response that leads to low blood pressure and organ dysfunctions. We have to give this in hospital. You have to have the ICU and the neurology doctors and everybody ready in case a patient does have those reactions so that you're able to treat them safely. But once they get over that hump, they can receive as an outpatient, but it takes a lot of setting up. So we really have to believe in something in order to convince my hospital, which is already overstretched resources, to give this. But right now, it's for small cell lung cancer patients who've had multiple lines of prior therapy. And we're seeing those patients who do respond to this therapy, sometimes the response is a year or more. And when you start off with a diagnosis of extensive stage or incurable small cell, that's what we quote you as your survival, is about a year or even less. And so this is really remarkable. It's going to very quickly move through in drugs like this up into not only earlier stages of therapy, but also probably curative intent. So how is this drug working? Well, here the bispecific is not just hitting 2 targets on a cancer cell, the way that we saw with the amivantamab. Here you can see one of the targets, because that thing in the middle, the versus tarlatamab, the red is attached to the cancer cells target, and this is the target called DLL3, which is expressed on almost all small cell lung cancer on the outside, but not in healthy cells. The blue side attaches to the T cell. And that's pulling that T cell. The T cell is the cell that wants to come and kill the cancer cell, and it's bringing them together. This is our matchmaker drug. And it makes sense that immunotherapy would work in small cell lung cancer. It's a very highly mutated cancer, but we only got that 1 in 10 when we use our usual immunotherapy checkpoint inhibitors, which take that break off. Because sometimes there's little breaks on the cancer cell that when the T cell comes by, it just won't do that last step to kill it. And we couldn't figure out why it wasn't working so well in small cell, but we realized it's because the T cells can't even get close. They have these bouncer cells, they call them Tregs, and they have all these different things that are keeping the T cells from even getting close to the cancer cell. But this drug is going around that by pulling them together. And so these drugs are really revolutionizing our ability to treat. And so that's why it's very top on my to-do list to get this program up and running so that our patients can get access to these therapies. So this is an example of cellular therapy, but also bispecific. So we can see how these concepts all come together and we mix and match, and we take the science, we apply it to drugs, and then sometimes we find a drug that works, it doesn't, then we go back to the science. But this is really how things are changing. So my final thoughts. These improvements in all modalities of treatment for lung cancer have translated to better outcomes, not just survival, but patients living longer before progression of their cancer, living longer before recurrences, and ideally having their best quality of life, able to do what they want to do, living their best life. We have to work as advocates, bringing it back to Lung Cancer Canada, our Nova Scotia community, to make sure that our Nova Scotian patients have the best access to these therapies. Unfortunately, right now we're tied with Newfoundland for the highest mortality rates from lung cancer in the entire country. And so we need to do everything we can to help all our Canadian patients, but in Nova Scotia, we have to work extra hard. And so that's where advocacy comes, to make sure that we have drug funding that makes these drugs accessible, especially oral therapies. If it's funded in Nova Scotia, it only means it's funded if you're a member of Nova Scotia Pharmacare. So if you're older than 65, that's easy. But if you're less than 65, and God forbid you don't even have private insurance, and I want to give you a drug that costs $12,000 a month, we're really struggling. Unless your uncle is Mr. Irving or Mr. Sobey or something that, I don't know, that you're sitting on a ton of money. Those are sometimes drugs that we can't access. And I see patients coming back to see me in clinic, one of whom is married to someone in the Navy and has that great Canadian Forces drug plan, and she gets to walk out with her targeted therapy. The other one goes out and gets chemotherapy. So we really have to focus on equitable access to all our therapies for all our Nova Scotians. We need to do some fundraising to get Dr. Wallace that robot. She's not here yet, so I was hoping that would make her laugh, but she wants that robot bad. And it's not just because it's a fun toy for a surgeon. We do know that patient outcomes are better. It raises the standard of care so that all surgeons should be able to operate like those few magic ones that we know about and that they'd like to tease. Say, I can do that if you just give me the machines to help me. And finally, in Nova Scotia, as we've already given you an example, we're very, very motivated to open up innovative research trials. I get very excited by the science. And so I probably get 3 or 4 proposals to look at a different research trial every week. Chelsea knows how many emails I get for that stuff and trying to set up the meetings to review them. And not only do I want to pursue trials that I believe in terms of science, but I also want our Nova Scotia patients to have access to therapies that we couldn't otherwise have. So I really believe in these vaccinations, these personalized vaccinations. There's really great basic science behind that. And so if that's going to be the wave of the future, I want a patient of mine in 2025 to have a chance to access that through the research trial. We get so excited about those. So we have to hurry up with contracts and get that open so we can get that going. And so again, thank you. Thanks especially to Michelle, MJ, and Chelsea. Thank you to those nurses and physicians who promoted today's event, promoting things like the Give a Breath Run, to all the speakers who are joining us this evening, but most importantly, to those of you who have joined us, our patients, our caregivers, because you're the reason that we're all here. So thank you very much.
Are there any questions for Dr. Snow? Yes, you did a little bit, but okay. But you can always talk to everyone. So thank you, Dr. Snow. I'd like to introduce now to Dr. Robin Urquhart. Dr. Urquhart is an associate professor and Canadian Cancer Society endowed chair in population cancer research in the Department of Community Health and Epidemiology, with cross appointments in the Department of Surgery and the Division of Medical Education at Dalhousie University. She's a senior scientist with the Beatrice Hunter Cancer Research Institute and an affiliate scientist at Nova Scotia Health. Her research program focuses on cancer from primary prevention to survivorship and palliative care.
Thanks for having me. Um, I'm going to talk today about environmental exposures and lung cancer risk. That was a great talk. I hope my talk isn't meant to be negative. It's meant to be positive as well. So let's remember that. It's great to be here. Thank you very much for organizing this. I have to say, I feel like I do a lot of, I do research in a lot of different cancers, and there's something about lung cancer that sort of tugs at me all the time. I'm really passionate about lung cancer and improving access to therapies and access to care and improving quality of life and all of those things. So I'm really happy to be here. I just got to figure this out now. Let's see. Okay, so I'm just going to talk about some work. I'm going to talk about environment and lung cancer, and then talk about some work that a number of us here in the room have been involved in for the last couple of years around trying to understand better in the environment and environmental exposures and lung cancer risks so that we can actually act on it, right? So that we can actually sort of maybe prevent more lung cancers, but also sort of detect them earlier. So it'll be a little bit of a different talk. I've got some of Alison, Dr. Wallace's research in here as well. I was hoping she was here, but we'll tell her we talked about it. I'm putting this up here. It's true, actually. It's true, and it's actually really, really nice to see that our lung cancer rates are starting to decline a little bit. And a lot of that is tobacco cessation, sort of reduced, but also is improvements in treatment. It's unbelievable to think about the progress in lung cancer. This is not what I'm here to talk about, but it blows my mind to think about the progress over the last decade in particular in lung cancer treatments. We're still a country though that has a lot of lung cancer. So this is just sort of a big map. It's age standardized mortality rates for lung cancer, and you can see here Canada's deep red. So we're the highest in the world, even when we're age standardized. So we account for age and the older population. And we're still, despite the fact, mortality rates are declining, we're still in this situation where more Canadians die of lung cancer than if you took breast, prostate, and colorectal cancer combined. And so we still got a problem here that we're trying to figure out from all these different ways. In Nova Scotia, we do have amongst the highest incidence rates, so age standardized, again, incidence rates in the country, and mortality rates. And some of it's attributed to smoking. So the number one risk factor would be tobacco use for lung cancer. I'm not sure if it's all attributable to smoking. And so that's what I want to talk about today. This is a quote. This was Dr. Drew Bethune. He's still around, although he's retired. He was a thoracic surgeon here for a very long time in Halifax, and then was head of the cancer care program in the province. And I used to meet with him a lot when he worked. He retired, I don't know, 5 or 6 years ago, maybe. And I remember having these conversations, and whenever we talk about lung cancer, because we talk about some of the research I was doing, he collaborated on a lot of my research. And we talk about it, and he would just shake his head, and he's like, there's something going on here, Robin, and it's not explained by smoking. I don't understand what's happening in this province, but there's something happening that's not explained by smoking. And so that sort of piqued my interest in environment and what's going on, and is there something that's happening? Here's a map. You're not expected to see the small parts of it here. There was a really nice paper published a number of years ago by some colleagues of mine, and they really looked at lung cancer rates, age adjusted again, in Canada versus Sweden, and then looked at the rates of all the different risk factors that are out there. And so what they found was that in Canada, our age adjusted incidence rate, so the rate of getting lung cancer, is about 163, so 163 times greater than that in Sweden. So we have higher incidence rates. But our smoking rates are about the same. Our climate sort of similar, our demographics similar, smoking cessation rates, like tobacco cessation similar. So what's going on there, right? So they looked into some different environmental factors, just kind of observationally, like just looking at this at a high level. And what they found was that new homes in Canada have 457% higher levels of radon than the equivalent homes in Sweden. Interesting, right? Interesting. And we know radon is, at least in Canada, the #2 sort of contributor to development of lung cancer in this country. So we're going to talk about radon in a minute. We think of lung cancer often, or at least I grew up thinking about lung cancer. The first person I ever knew that sort of very important in my life who died of lung cancer. She was my great aunt, but she was actually my babysitter when I was like, growing up before I went to school. And I remember her being diagnosed and she didn't live very long. This was a long time ago now. There weren't any treatments or many treatments available. And we sort of attribute it to smoking, and tobacco is the #1 sort of contributor. But if we look at lung cancers, diagnosing cancer in Canada today, 1 in 5 are in people who've never smoked. And that depends on where you are in the country. In some areas like BC, it's actually a little higher than that. It's more around 33% in BC are diagnosed in people who've never smoked. So it's not just tobacco. And I want to say here, I don't like the stigma around tobacco because it doesn't matter if you smoke or not. Like I don't want that to come across because it really actually doesn't. There was a huge settlement not that long ago, last year, with the Canadian government and tobacco companies. And if anybody ever wanted to read through that whole settlement, you would understand what tobacco companies did to keep people addicted to tobacco. So I don't want any stigma or anyone to think that I feel like that. But we know today in Canada, 1 in 5 are in people who have never smoked or higher, depending on where you are in the country. We also know that lung cancer has a lot of non-tobacco causes. So I talked about radon a minute ago in Sweden. So we know there are other causes. Arsenic is one that we're studying here in Nova Scotia and in Canada. Air pollution. So worldwide, air pollution would be actually the #2 contributor. It's just, we've been really lucky in Canada. We don't have the same levels of air pollution than like if you go to sort of parts of Asia or other parts of the world, right? But air pollution is certainly another huge contributor to lung cancer and just lung health, right? Like lung disease in general. So I'm going to talk a little bit about the radon, arsenic, and air pollution. They're not the only sort of environmental exposures that we have, but they are sort of prevalent, like high or growing in Canada. So this is just a map of, this is old now, this is from 2019. I have another map in a minute, just looking at sort of the percentage of homes with high radon levels in Canada. Yeah, you can see here the percentage of homes that have higher than the maximum acceptable limit. And so what radon does, I mean, it's a radioactive gas. We breathe it in. If you're out in the outside air, it's really not contained and it's okay. It's really when it's contained and concentrated in inside air. And what it does is essentially it's radiation particles that it's emitting, right? So it's banging our cells constantly and it creates sort of damage to our DNA. And when our DNA is damaged, we start to get mutations and it puts it at a higher risk for getting lung cancer. So here in Canada, we have in certain parts of the country, we have high levels of radon. We know it is one of the leading causes, the second leading cause of lung cancer in this country. And we're actually, I think there's a lot of awareness now around radon, and we can chat about that if we have time. But Canadians are the second most exposed people in the world to radon. So it's our geology. It's where we live. Like we can't really do anything about where we live in that sense. But we can do things about airflow and containing that gas in our homes or in our workplaces. Here is a map actually from just October 2024. This report was released from Health Canada. Fascinating readings. It's a really nice report that's brought together all of the latest scientific evidence in Canada around radon exposure. And if you look here, I want to walk over here because I'm a bit of a teacher when I teach at the university. If you look here, Atlantic Canada and the Pacific Interior and Yukon, 1 in 3 homes in Atlantic Canada and Yukon Pacific Interior have above the maximum acceptable levels of radon in the home. So we're amongst the highest in the country. You can see here other parts of the country, the prairies, 1 in 5, central sort of Ontario, Quebec, 1 in 6. And there's only one place in our entire country where there's not a lot of radon, and that's Pacific Coastal. So the geology is different, essentially. But this is a really nice report that was just released, and hopefully it spurs, we talk about like advocacy and action, hopefully it spurs some action in the country, particularly around things like radon mitigation and better building codes and housing and so on. So here's an arsenic map. So another map of the country, the black spots, this is an old map now, but it still holds true. The black spots are like known as the arsenic hotspot in the country. So you can see Nova Scotia is an arsenic hotspot, as is other parts of Atlantic Canada, parts of BC and the prairies. Arsenic is often found in like our groundwater. And so if you're on well water and you're drinking that water, it's also in some of the food that we eat. Certain parts of the world have really high levels of arsenic in their water, like Southeast Asia. So there's a lot of water, or there's a lot of arsenic in rice, actually. So the high rice diets and so on. So we do get it through different ways. In Atlantic Canada, it's mostly through well water. If you're on a well in a hotspot in high arsenic areas, and so it's around 12% of all wells in Atlantic Canada that have been tested are above the maximum level of arsenic. The maximum level again is, I mean, we don't have to get into this. I think for both radon and arsenic, the maximum levels are fairly high, and you know they're sort of a little bit, they're based on evidence, but they might be higher than some people would want to see. The thing with arsenic is it does the exact same thing as radon. It basically causes DNA damage in our body, and so it creates like mutations in our cells and puts us at a higher risk of cancers, but not just lung cancer, sort of bladder cancer, kidney cancer, colon cancer, different cancers as well. So I'm going to put up a slide here, and it is from Dr. Wallace and her team and the work that they've been doing very recently. And it goes back to something happening in Nova Scotia or maybe Atlantic Canada that we can't quite explain. So don't need to read this. So this is it's called a preprint. And this was a article that was sort of published as a preprint just this year in 2025. It's called Multiple Primary Cancers in Lung Cancer Patients in Atlantic Canada, Implications for Screening and Management. Essentially what her and her team found, they did a complete chart review of every new lung cancer patient, a new primary, so a new lung cancer that showed up to thoracic surgery here in Nova Scotia. They did an entire chart review. They went through all the charts to understand, okay, what's happening, what have we seen, what's, you know, in patients. And what they saw was that 43% of all of those patients that were referred to thoracic surgery for a new lung cancer actually had multiple primary cancers at the same time. So not like metastases, not a met to a different, actually entirely different cancers at the same time. And that's 4 times higher than has been described anywhere else in the literature. So this is sort of going back to, and it wasn't explained by age, a person's weight or BMI or smoking. Or smoking. So this goes back to what Dr. Basile used to say, right? There's something going on here and we don't know what it is, but it's not all explained. The other exposure that I just wanted to talk about briefly is air pollution. We've been really lucky in Canada. We haven't had a lot of air pollution compared to the rest of the world. We're getting more. And so if folks here, you know, remember 2 Mays ago, maybe with all of that forest fires here, you know, just outside the city and so on. And then we're getting all the forest fire smoke at different times from Quebec or Northern Ontario and different parts. I mean, we're getting more air pollution. This is just simply a map of sort of what we call PM 2.5, tiny particles. That's all it refers to, is small particles in the air that are, and that's the size, that are 2.5 microns or less. But essentially they can go deep into your lungs when you breathe them in. And that's just a map of sort of concentrations of these particles from May to September over time from wildfires. And you can see, if you could see really closely here, you can see it's growing in Canada over time. We're getting more little tiny particles in the air that are lodging into our lungs and, probably going to impact lung health. The thing that happens with air pollution, these little particles, it's a little different. It's when we breathe them in and they lodge into our lungs and so on, they actually just cause an inflammatory response. We're sort of then in this chronic inflammation sort of mode if we're breathing this in all the time. But again, that sort of triggers lung cancer development. And this is sort of what worries me. We've seen such good strides in tobacco control, worldwide, and Canada's done such a great job. There's still work to be done, but we've done such a great job in tobacco control. But the burden of lung cancer, that's what I mean here, might increase in the future because of a number of things. One is climate change. So that first picture is meant to represent climate change. So very simply, when we think about it, I mean, we know that we're getting more air pollution, more forest fires and that sort of thing because of climate-driven events and so on. Radon. So if we have more permafrost in northern Canada thawing, you're going to release more radon, right? So these things actually do matter. Arsenic's really interesting. So if you take the combination of drought and flooding and higher temperatures, what's happening is that more oxygen is going into ground aquifers, and that releases more arsenic into water and so on. So we're actually seeing more of this, and some parts of the world are more affected than others. It's just Southeast Asia and Bangladesh, for example, around arsenic, because of the flooding and the increased temperatures and the flooding and the increased temperatures, it's increasing arsenic to huge amounts. And so this is happening because of climate change. Housing. My kids don't believe this statistic, but it's true. I've had to show them. 2050 is only 25 years from now. 70% of the housing we need to house people for our population growth projections in 2050 is not built. 70% for 25 years ago, we don't have yet. So we need to build a lot of houses in this country, which I think housing obviously is a big concern right now. But also, if we don't have building codes that actively take the radon out of our homes, we're going to see more radon exposure and higher levels of radon exposure. So again, this is a bit of an advocacy issue to make sure that we have better building codes. And the other thing is COVID. I feel like most people are tired of hearing about COVID. COVID's really interesting. I mean, what it did was, in a really, really quick way, worldwide, really, really quick, it caused a lot of lung injury in people. Massive, widespread lung injury. We don't know what the impact of that's going to be. We don't, because we're still studying it, right? But there's a lot of people who believe that lung injury and that inflammatory response in our lungs is quite similar to the inflammatory response that we get when we have pneumonia. And we know pneumonia puts you at an increased risk of lung cancer in never smokers. Very similar to the inflammatory response in air pollution, which puts you at an increased risk of lung cancer. So it's quite interesting to think that this event we just went through that was life altering, not just lung cancer, there may be other things as well, right? That it impacts the body, and we don't know yet how it's going to impact the body. But we might see more lung injury and more lung cancer long term because of this virus. Okay, so I'm going to talk the context there and then talk about lung screening. I am so happy we have lung screening in this province. It makes me so happy. I am a huge proponent of lung cancer screening, as I think we probably all are. There's evidence out there that it reduces mortality. We're starting to see impacts in BC. Like, it is just unbelievable. And from my perspective in the environment world and environmental risk, what we're really trying to do is to figure out how to broaden these criteria in an evidence-based way, not just broaden it without the knowledge, right? We need to understand how to. So right now across the country, as we get lung cancer screening programs, they're based on essentially tobacco history, smoking history, and age. But I just told you, there's people who get lung cancer who don't smoke, right? And actually, if you look at some of the data coming out, and I was speaking to a colleague in Alberta who runs the lung screening program there just recently, and he was saying about 40% of people in Alberta who are diagnosed today wouldn't be eligible for lung screening. So some of them have never smoked, but some of them are light smokers, or they just don't smoke enough, right? That's a big number of people, 40% who wouldn't be eligible. So we believe, based on what we know around radon and arsenic and so on, that there has to be a way to figure out if someone's at high risk because of those environmental exposures, not just tobacco, in addition to tobacco. So there was a report released last year from the World Health Organization as an example, that showed us, took all the information, all of the evidence out there, all the science that's out there, and actually said that for people who use tobacco, they smoke, and they have long-term exposure to radon, their chances, the risk of developing lung cancer is 25 times people who do not use tobacco and have the same exposure to radon. So it just escalates, like it intensifies. We would call it synergistic. Like it just, so it's important to everybody. So a group of us came together. I'm just about done here. A group of us came together a couple of years ago and thought, you know what, we need to better understand these environmental exposures. Like, we know that there's an increased risk, but what does that mean for an individual? Like, what's your increased risk based on exposure to radon or based on exposure to arsenic, for example? But we need to understand that. And then we've got to use the information to develop prevention strategies, but also to broaden screening criteria, again, in an evidence-based way. Like, who are the people at high risk so that they also have access to screening? Again, for Canadians who don't, or, occasionally or at a low sort of level of tobacco use. This is really my last slide. So some of the work that we're, except for the slide of the team members, and some folks are here, so that's awesome. This is my last sort of slide. So broadly speaking, these are our 5 goals of this research program that we have right now that's being led out of DAL, but it's national in scope. We've got investigators from all across the country, all the way to BC. This is sort of what we're trying to do, and I'm only going to talk to this at a just sort of high level. So one is we're trying to identify biomarkers, things in the body that might help us identify if someone is at high risk for lung cancer because they've had chronic maybe radon exposure or chronic arsenic exposure and so on. So one of the things and then we're correlating that, looking at people who've developed lung cancer and people who haven't. But one of the things that's interesting, if you think about it, radon is a gas. What happens in the body is that actually, as it's broken down in the body, it actually becomes an isotope of lead in the breakdown process. And that isotope of lead, the only way you can have that in your body is through radon exposure. So can we measure that? Like, are there biomarkers where we can say, you know what, you have this level of lead isotope, therefore you're at a high risk of lung cancer, and you should be screened. So that's one example. We've been looking a lot at arsenic in the body too. So different ways that that's broken down and trying to track the chronic arsenic exposure. We are close to, especially in radon, we know more about radon, to sort of developing a personalized lung cancer risk measure that, again, is based on byproducts of radon exposure that we want to test within the context of lung cancer screening. So let's actually compute individualized risk based on radon. We could all, and the tobacco and age as well. And actually start to let those people be screened and test and see if we're finding lung cancers and finding them earlier. Interestingly, this is a little different. It's an engineering part of what we're doing. We're developing a monitoring system. We have developed it actually at this point. We're figuring out how to sort of put it out in the field and what we're going to do that allows us to capture air pollution, these little particles, and then see what's on them, and then sort of and then sort of test them in animal models to understand what it does to the body. And I say that because what we think is these little particles, PM 2.5, on their own probably aren't that dangerous, actually. Just breathing those in probably aren't dangerous. Probably it's what's on them. So if you've got those little particles with arsenic on them, because they're next to a gold mine and you've got arsenic, like that's what's dangerous. Or so a forest fire in BC and a forest fire in Nova Scotia might actually have different risk levels, different danger levels. So that's sort of where we're going with this. We're trying to figure out what's actually on those air particles and what's that then doing to your cells, right? Like what's that actually happening? The other part we're doing is speaking to communities. So we're just embarking on this actually. We're just putting in the research ethics proposal and protocol to really go to communities that we know are at high risk because of radon or arsenic or air pollution, or there's many communities in this country. It's interesting as we were sort of scanning this that have all three or have at least two. And speaking to people in the community to understand, okay, so how do we communicate about risk better? And then how do we sort of help the community reduce their risk, and what sorts of things should we do in the community? And then we need to let people know about what we're doing, right? And because the ultimate goal in the end is prevention and to broaden screening. And so it's such a great partnership. Many of us across the country are involved, work with the screening programs, and there's such an opportunity here. And I'm so excited because this is out of Nova Scotia. This is world leading work out of Nova Scotia. It's so great. Anyway, here's the whole team of the work that I was just talking about in the end that we're working on. And Stephen's here, and Jennifer's here, and Stephanie's here, and Alison will be here in a little bit. And I'm a researcher and I'm a professor, so this is what's going to excite me. Sorry if it's so boring, but we have 23 people, 15 in Nova Scotia, who are getting training under this right now. So we're building people to be the researchers of the future and the clinicians of the future who are really interested in environment and lung cancer. And I don't know anywhere else in the world really where that's happening. It's really, really exciting. So anyway, I'll stop there. Thank you very much. Oh yeah, questions? Yeah. There are studies done on secondhand smoke. We're not looking at secondhand smoke here in this work, but there are studies that would show, and Stephanie, you might be more on top of this if you want to answer it, but yes, there are studies that have looked at secondhand smoke, and they're sort of uncertain, but there is a risk. Yeah. Yeah.
For all the occupations and people that have worked for years, restaurants and bars, they didn't feel old enough to remember.
Yeah. 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 We're not, sorry, I was going to say, we haven't looked at that because hopefully it's less, but occupation is where we are looking at doing some work. And it is restaurants, and it's just these places where people, hair salons and so on, where where people smoked, right? That's where, yeah.
My question was the isotope that educates was it cumulative over a lifetime or
no? So it depends on what you're looking at in your biomarker. We're actually spending time right now looking at toenails, because toenails can really tell you what you've been exposed to. Let's say over the last 9 months or so, it accumulates. It's all different in different people, but say 9 months or so. So we can look at the accumulation of arsenic and lead and that sort of thing in toenails. But at the same time, we're getting like a huge amount of information from people. So there's questionnaires so we're in the process of actually sending out questionnaires and asking people to collect toenails and that sort of thing to 5,000 Canadians, but we've already done a whole lot of it as well. So the questionnaires also ask about like, where do you spend most of your time, what your activity levels and so on are, because if you spend and radon kits. So if you spend, and we're putting all that information together, because if you have high radon in your house, but you barely spend any time in your house, right? Or it doesn't matter so much. So we're actually, to develop this personalized risk measure, we're having to bring in like where you spend a lot of your time and that sort of thing and see thresholds. Yeah.
I just wondered if it could include exposure content, but that's not.
No, our bodies are really good at like getting rid of waste in our bodies as well, right? And so for us, toenails work really well because of a couple reasons. It doesn't usually have as much product as hair. Hair you could look at as well, but like hair sometimes it's just, there's more product in it and it's been exposed to more things than toenails. And so if you keep your toenails product free for about 6 weeks, then they're really good at being able to tell us what you've been exposed to for that period of time. That's what we're doing in the study. Right now, it's not available to everyone, but how would I get information out around that? But we are starting. It is Dr. Godarzi, yes. And so I would just, okay. So he's sending everything out. It's interesting. I was just talking to him yesterday, and I hope this is not a secret, but Canada Post says they're going on strike again. So we were trying to put it all out last year for the winter, and we couldn't because of Canada Post. And now they're saying May, they're probably going on strike again. Okay, yeah. Yeah, okay. So it's just funny that we're trying to get these out to collect all of this information, and it's hard because we're dealing with like trying to figure out strikes and everything. But if you could give people information about Dr. Godarzi.
So just if you can,
Yes. Yeah.
just.
Yeah.
So,
Oh, so we want people so it's evict radon, evict, EVICT radon. And what we want are like people who have who know they have high exposure or low exposure. We want both. We want people who've had lung cancer or not. We want people who have used tobacco or not. Like, so it's a wide variety of folks across the country, rural, urban, because actually where you live really actually is quite important for radon. So people who live in rural areas across the country have higher levels of radon in their homes. So I'm trying to think I think we're asking people for 3 months, so like to continuously monitor for 3 months, although 6 months is probably a little better, but yeah. As long as you've done 3 to 6 months. If you just check for a week, you can't be. Yeah. Okay. Yeah. As long as you check for like 3 to 6 months is better than 3 months, just because of the variations and stuff. Yeah. Yeah.
They're keeping national and it's important to deal with it. There are other places where that great, they're all well. They're keeping the information and database all across Canada. So it's giving a much better picture of that for you personally, who are contributing to the national memory bank, where the major radar. One home in the community may have a radar or scale.
It's yeah, it's very true because of how the house was built and everything. Also, if you're on well water or not, because the radon will come in not through your water itself, it's around the piping, like that the well comes in. So that's why rural have okay, yeah. And mitigation is really effective. I want to say mitigation. I saw, can I just speak for one? I saw someone talk about Sweden. So someone from Sweden, sort of, he was a big radon expert in Sweden. And I just saw this last year and I saw his talk at like a meeting I was at. And it fascinated me because they've done a lot of work in Sweden around building codes and so on, like housing, but also around public, like where people work. Because like teachers are actually at high risk for radon, right? Because they're in the schools all the time. And so, but in Sweden, like now they've had really good codes around like hospitals and schools and churches and things. And he showed these data where they do like active ventilation sort of thing. So they turn them on in the mornings. And so you can have a school, someone comes in the morning, turns it on on a Monday morning at 7 a.m. and they monitor radon. So on the weekend before, the radon levels are like really, really high, like 4 times, you know, the maximal limit, but no one's in the school. They come in at 7 a.m., they turn on this active ventilation. By the time the kids come, it's almost 0 in the school. And they keep it in the week and they turn it off Friday evening and it goes right up again. Like it really is. Anyway, there's good mitigation. I don't know anything. I'm not an engineer. I don't know anything about building codes, but it's really fascinating to see. No. Yeah. Yeah. Yeah, yeah. And we can, like, one of the things about equity, right? Like, the thing is to mitigate a home, if it's your personal home, it costs money. And some people can afford that, some people can't afford it. So, like, we need to make sure people can have access to mitigation. Yeah.
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 Yeah, absolutely. And I know that some provinces have funding available, some don't. You know, some are dropping it.
Some do, but it's hard to know what it is,
Mhm,
right?
that too. So before we are a little bit over, but I think we're okay because I did schedule quite a long dinner break. I'd like to introduce Stephen Sollows. Stephen was born and lives in Southwest Nova Scotia. He and his wife Janet have 3 adult children. He's a retired electronics technician and a community volunteer for several local charities. He enjoys outdoor hiking, biking, skiing, kayaking, and playing with unusual cars.
Thank you. Pardon me? Unusual, well, I mean, don't get me started. I just bought one today. Speaking of hope, yeah. Good evening to everyone. Oh yeah, sure. Oh yeah. Yeah, I'm not Dalhousie University.
I'm just going to stop sharing for a second while you speak.
Thanks. It's just 23 years we're celebrating, I think, or maybe longer with Lung Cancer Canada having summits now. Close to that. Okay, okay. Yeah, that's cool. Um, my name's Stephen Sollows, and I am a stage 4B lung cancer patient who has the absolute privilege of living well and feeling well almost 5 years after being diagnosed. I want to state, though, that I know that every individual person with lung cancer has a different story. Mine is unique to me and may not be or reflect the experiences of others. The reason that I say that I am privileged is that my life experience tells me that it's been just that. I'm a white male who was brought up in a loving family in perhaps the best country in the world. My father had a regular income. We lived in our own home with central heating and running water. We had lots of food. We owned a car. I never in my life needed anything. When I grew up, I had my own successful business. Didn't pay a lot, but that was not an issue as I was good with money anyway. I married and my wife Janet. Hi, Janet. My wife Janet and I have 3 great kids, one of whom is here with her partner. Hi, Emily. Hi, James. I was always very healthy and very active, and I loved my life. Still do. But in the spring of 2020, I was having some pains in my back. I went to my doctor, and over a period of about 4 months, eventually it was decided that I should have an X-ray. Later, I was sent for a CT scan as there was something that was a bit fishy on the X-ray and they couldn't tell what it was. That was on a Thursday. And then I got a call from my doctor early on a Monday morning and asked me to meet him at 8:30. So I suspected it was bad news, but I didn't expect this. My doctor sat me down and he said, well, I've got some bad news to share with you. You have stage 4 lung cancer. It's in your lung, it's in your spine, it's in the bones of your spine, it's in your hip, it's in your pelvis, it's in your ischium. And I said, wait. I have to write these things down. Oh, and he said, it's probably in your liver as well. Well, that was shocking to me. How could that be? I remember leaving the office, sitting in my car and just saying, shit, 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 shit. And I remember I said it 5 times. Now, what do I do? What do I do? I don't think everyone is ever prepared for that kind of news, but we have no choice but to take it, to digest it, and then to act on it. I had known of acquaintances in the past who had stage 4 lung diagnosis, and within 3 months, they had all died. So we're a close family who is aware of others' lives. I would have to tell my wife and my 3 children. How would I do that? Well, I'm a direct person and I prefer that, and felt it was best to be direct with my family. I went home and told Janet immediately, and when my son Steen came home, we'd tell him too. We decided that with the other 2 kids and their partners in other areas of the province that we would do a FaceTime meeting in the evening. That was perhaps the most difficult time of all. We got through it though. I had also decided that I would not keep this to myself. It was fine to share any detail with anyone who wanted to know it, and I still feel that way. My reaction to my condition may seem strange to many, but I'll tell you what happened from my privileged point of view. The first 2 days sucked in that I was trying to figure out what to do quickly to lessen the burden on my family of my accumulations of life's stuff. You all know what that's like. We all collect stuff. It's that junk that you accumulate in your life that you can't do without. Well, I had collected 63 years of it at that point. Once I took some action on that and then realized that this accumulated junk didn't really matter, I quickly came to a sense of peace with whatever was to happen to me. You see, I realized that I had already had 63 years of an ideal life. And from a world perspective, I was already living a long life. I'd never wanted for anything. My wife and family would all be fine with no worries. There was little else to take care of other than some tough family conversations. My treatments to date have been relatively easy for me. After my initial diagnosis, I was quickly referred through the medical chain for my various treatments, radiation for the cancer in my spine and my back, a biopsy on my lung cancer to find out what it was. The tough part of that then was waiting for the results of the biopsy. That would take almost 3 weeks. Then a call back for the results. When I first met with my oncologist, Dr. Stephanie Snow, she had told us that there was a possibility that my cancer may have been caused by a genetic mutation. As I recall, at that time, there were approximately 10 types of genetic mutations associated with lung cancer. And of those, 6 of them had life-extending treatments, which might be available for some folks, and that could extend one's life. I can still remember her coming into the room and reminding me of that conversation after the biopsy results had come in. That day, I won what I call the most important lottery of my life, when a biopsy showed that I had non-small cell adenocarcinoma, and it was an EGFR exon 19 deletion, and I was told there was a targeted treatment for that, which could extend my life. It was a single pill a day. I started on that treatment immediately, and it worked. My lung tumor started shrinking, my back problems improved, and suddenly I was back to my busy life, and I generally felt great. It seems so strange, but it is true. I was told that specific treatment might extend my life for 2 or 3 years, or even more. That was almost unbelievable news at that point. That was almost 5 years ago, and I'm still here. Through my treatments and rubbing shoulders with others in treatment, my sense of privilege has become more apparent to me. I can clearly see some of the inequities in the system that have caused barriers to others who may not have had the same privileges as I have. I was born in an area, Nova Scotia, mind you, I'm on the southwest tip, where I could be diagnosed quickly and get the treatment needed. I was easily able to navigate most of the complexities of understanding my condition and taking the actions needed to help myself. I had the funds to provide transportation and food and housing for myself when I had to travel out of my community for treatment. I understood the processes, demands, and responsibilities of being a lung cancer patient. This is not the case for all of my fellow Canadians. The inequities across our country are many. For example, how lucky I was to be living in Nova Scotia, where significant costs of take-home cancer medications had just and are now mostly covered through the pharmacare or seniors pharmacare programs, making expensive take-home cancer drugs affordable for most patients. Some provinces have not yet addressed this issue. In my case, my targeted treatment was $12,000 per month. That is huge. Another medication I take to help regrow the bones in my spine and so forth. I think that's about $1,100 per month, actually. A national screening program for those of higher risk is necessary to save lives. It's interesting how all three speakers have hit on this. And it's now encouraging, though, to see this program being adopted in many provinces, including Nova Scotia, yet a national program would seem so much more sensible. What about communications for those patients who don't have phones or computers, or those who do not have any internet access for such simple things as making appointments or communicating with hospitals and doctors? There's still a lot of work to be done. Lung Cancer Canada, as many of you know, has many good programs providing supportive services and information for us. For the Excel exercise program, tailor-made for lung cancer patients, to the monthly Airways of Hope support group meetings and online counseling services, Dr. Paul Wheatley-Price also has his Voices of Lung Cancer podcast series and has special guest speakers, including some of the world's leading researchers, as well as patients addressing the many issues dealing with lung cancer. All of these many services of Lung Cancer Canada can provide hope, help, and direction for all of those, or all of us, living with this disease. Other programs that they have include the National Lung Cancer Summits. Here we are. The November Evening of Hope, and there are other programs as well. So to wrap it up, I have to say that I do live with hope, and my well-being is in part due to the help and support that I have received through the various Lung Cancer Canada programs. Being able to maintain a healthy, active life despite my condition has been an unexpected and happy outcome for me. I feel truly blessed. None of us really know what tomorrow brings, but yesterday was a very good day for me. And perhaps tomorrow will be too. I can tell you, I was cleaning out I was cleaning out litter in the ditches last night, and I felt great. I had a big smile on my face. Most people look at me and think I'm nuts when that happens. I had a great day today too, and I'm pretty sure tomorrow will be good. And that's good enough for me. Someday there will be more challenges, I know, but that's not a great concern for me today or tomorrow. I do still have hope. What I was going to say was, when I was first diagnosed, I remember I was looking at my shoes when I was waiting to go in for radiation treatment to my spine, and I had old sneakers on, and those were my good sneakers. And I thought, oh my gosh, I need new sneakers. If I'm only going to be around for 3 or 4 months, why would I go buy new sneakers? And it sounds silly, but it's absolutely true. We do this sort of thing because in reality, you don't know what tomorrow brings at that point. To show you that I still live in hope, even though I'm 5 years in on this medication that was hopefully going to last for 2 or 3 years. Yeah, we bought a new car today. New to us car. I don't buy new cars. What can I say? Anyway, I hope you enjoy the patient summit, and thank you very much for allowing me to speak.
Well, thank you so much, Stephen, for the endorsement. And I have to say that you are part of the success of our program. You're always there on the national support group, providing support to all the others. And how many times have I contacted you to give one-on-one support? So I'd like to thank you. Without volunteers like you, the programs wouldn't work. So yeah, we'll break for dinner now. I do. Welcome back, everybody. And thank you for those online for your patience. I know we were a little bit late coming back. I would like to introduce Dr. Alison Wallace. She's a thoracic surgeon at QE2 Health Sciences Center in Halifax and an assistant professor of surgery at Dalhousie University. She completed a PhD in molecular genetics and is a doctor at the University of British Columbia. She currently serves as Director of Research for the Division of Thoracic Surgery and Vice Chair of Research for the Canadian Association of Thoracic Surgeons. She's the co-director of the QE2 Lung Tumor Bank, which was established by Dr. Zala Zhu in 2005 and contains the largest collection of lung tumors in Canada. She's the lead investigator of the POWR study, Perioperative Outcomes of Lung Cancer Surgery in Women, a Canadian multi-center study using national registry data to uncover sex-based differences in surgical outcomes.
All right, perfect. Thank you very much for the introduction, and thank you very much for inviting me to talk here today. This is an amazing event. It's full of friends, colleagues, patients, acquaintances. It's really fantastic to be here. So today I'll talk in depth about a study we have called the POWR study. But before I get into the details of that, I'll just start talking about lung cancer in general and why I'm here. So I know I'm preaching to the choir. I don't have to tell anyone in this audience about how devastating lung cancer is. But I'm a thoracic surgeon. I'm also a scientist. So on a daily basis, I treat patients with lung cancer. And in the rest of the waking hours, I try to solve the problem. How can we make this disease go away? How can we make the journey for patients with the disease better? And how can we develop new treatments? So I'm originally from Vancouver. We saw lung cancer there. It was a different type of disease than we see in Nova Scotia. In Vancouver, we worried about high housing prices and earthquakes that we could never predict. But in Nova Scotia, there are some environmental issues that I know Dr. Urquhart talked about earlier, and we work closely together. But one other striking comparison that I think about a lot is if you look at Canada and Sweden, two countries with similar smoking rates, but also similar living conditions. For some reason, Canada has much higher lung cancer rates than Sweden. And again, just bringing that close to home here to Nova Scotia, we have some of the highest rates of lung cancer in the country, some of the worst outcomes. And we've also done work looking at how many lung cancers folks have and how many cancers in general. And we see that a lot of folks have more than one primary cancer. So all of that I've learned over the few years I've been here in Nova Scotia have really inspired my research program, which really has three main focuses. One on understanding the risks and non-tobacco causes of lung cancer. And I'm fortunate to work with Dr. Robin Urquhart and a number of very talented scientists, both here at Dalhousie and across the country. And on that work, really understanding the genetic and environmental factors that are driving the high lung cancer rate. Another branch of work is at improving the patient experience and outcomes. And I'll talk specifically about the POWR study in a few minutes. And Jodi Langley will also talk about our rehabilitation program, or Breathe Well, where we're trying to make sure folks are fit for the treatment and have a good quality of life and a successful outcome. And then I also lead and participate in a number of clinical trials, trying to develop new therapeutic options and again, improve outcomes. So the POWR study, I called it the POWR study, and someone told me to call it POWR. So it's Perioperative Outcomes of Lung Cancer Surgery in Women, and it's a nationwide study. So before I get into the details, I really want to thank the Lung Ambition Alliance, Lung Cancer Canada, and AstraZeneca, because they supported this work and funded this work. And it was through their support that we brought this study to completion. And I also can't talk about the POWR study without talking about Holly Philpott. Holly, like me, did a PhD before going to medical school, which is not the fastest route or the most common route. But she approached me and was looking for a research project that all medical students at Dalhousie have to do a research project. And she really drove the project and really did most of the work. And it was a wonderful experience working with her and having her expertise and knowledge involved in the work. So the background for this is that we know that there are sex differences in terms of lung cancer incidence and outcomes. There's a number of studies showing that. We also know that when folks are treated for lung cancer with surgery, a lobectomy, the most common type of surgical operation for lung cancer, comes with a cost. But if you have complications related to that, being major or minor complication, the cost really increases from 28.9% for a minor complication or 57.4% for a major complication. And then the other thing is that we've seen in our local data is the number of patients who have lung cancer surgery who represent to the emergency department within 90 days of that surgery. And in general, looking at all the surgical services, thoracic surgery does have the highest rate in general. And we see 38% of male patients and 62% of female patients returning to the emergency department for various reasons. And we've teased that out, but that's the topic of another study. So the purpose of this study was to assess differences in the perioperative profile between men and women undergoing curative intent lung cancer surgery. This was a retrospective study looking at patients who had surgery in the past 5 years. And we looked at the clinical features of patients, tumor and surgery related characteristics, postoperative complications, as well as mortality. And the overall driving force behind this work is to improve patient-specific management because everyone has a different path and a different journey. So CAT stands for the Canadian Association of Thoracic Surgeons, and there are not many thoracic surgeons in Canada. There's less than 200 of us. So we're a small group, and there are in Nova Scotia, there's one group here of 5 of us, and we treat all of Nova Scotia and PEI. And in other provinces, they just have a few centers. So about 10 years ago, one of the leaders decided that it would be good for us to pool all our data so we could really analyze it and make something of it with larger numbers than you can get from a single center. So they developed a national database. 12 hospital sites across the country contribute data to it. And there's various research questions that are being asked. And again, we got the funding from Lung Cancer Canada for this study, but also was selected by the CATS database team to use that database for this study. So the total number of participants was just over 9,000 to do this research project. So the main findings from the study are shown here. In general, men had higher rates of active or past smoking. Males also had more comorbidities, and that includes heart disease, diabetes, hypertension, and COPD. They also had poorer lung function than the female counterparts. Males had a higher rate of undergoing a pneumonectomy, which is the removal of the whole lung rather than a lung tissue sparing procedure. And in general, we saw differences in the histology or the cell type of the lung cancer originating with more males having squamous cell carcinoma compared to the females. In terms of lengths of stay after lung cancer surgery, the average was 5 days in our cohort across the country. Length of stay was almost 1 day longer in the males. Moving on to looking at complications, I'll just explain to you how postoperative complications are graded. This is the Clavien-Dindo classification system used internationally to grade surgical complications. Grade 1 and 2 are considered minor complications, and those are just a deviation from the standard postoperative course, or folks require medicine. Say you develop atrial fibrillation and need to take a beta blocker, something like that. When you get to grade 3 complications, these are complications requiring a re-intervention, maybe a chest tube be inserted, or return to the endoscopy unit or the operating room. Grade 4 means that the postoperative course required a stay in the ICU, either for single or multi-organ failure, and a grade 5 complication is a mortality. So again, looking at our national database and differences between males and females, we find that females had much higher rates of minor complications, and the males had higher rates of major complications and a higher mortality rate. So this is just the very beginning of a large body of work. Again, it's a retrospective study using a national database. There are limitations related to that, but this is really driving a number of research questions where we're looking at risk stratification tools to optimize the journey for folks. We're also tailoring our perioperative pathways, and part of that is our prehabilitation program that Jodi will talk about. We're also doing a prospective study where we're collecting all of the clinical and pathologic and surgical data, but also biologic specimens to look at differences in things such as inflammatory markers and things like that. And again, we'll look at much longer term outcomes, 5, 10, 15 years. And then the last thing is just improving equity in surgical care. So examining whether implicit biases or structural differences in care delivery contribute to sex-based disparities in treatment or outcome. So that's our summary of the POWR study. And again, I just want to thank Lung Cancer Canada and the Lung Ambition Alliance and AstraZeneca for supporting this work, for the CATS National Database, for allowing us to do this study and support us as well. Dalhousie University Department of Surgery supported us as well, and a big shout out to Holly Philpott, who really did the study. So thank you very much.
Thank you so much. So to introduce Jodi Langley, Jodi is a PhD candidate at Dalhousie University. Her research focuses on how oncology care providers can discuss physical activity with their patients in an effective and efficient manner. She previously was the Atlantic Research Coordinator for the EXCEL program, a pan-Canadian exercise program for people living with and beyond cancer. She started her fellowship in September 2024 with the Department of Surgery around designing a prehabilitation program for lung and esophageal cancer patients. Now, maybe.
If it's David doesn't.
No, I can. Hold on. All right.
My cool animations aren't going to come in. That happens when you try and do cool stuff with Canva. I got a pro account the other day and I've been having a lot of fun with it. Hello everybody, my name is Jodi and I am currently doing my PhD at Dalhousie University, hoping to finish up in the next little bit. But I'm here to talk to you kind of about the power of movement. Oh, the mouse. I don't know the last time I used a mouse. I'm showing my millennial life. I always use a trackpad. I'm going to talk to you about the power of movement and kind of what that means. To kind of get started,
I want to really kind of root where we are now in Mi'kma'ki. Part of the Breathe Well program is also working with Jabukduk here in Nova Scotia in the urban Indigenous communities to co-adapt the Breathe Well program for people living with and beyond lung and esophageal cancer in Nova Scotia here in Mi'kma'ki. So while we're very fortunate to, I know the weather's been off and on a lot lately, but to be on these lands. Oh, sorry. Old habits die hard. Old habits die hard. So I want to kind of really set the kind of tone here about the role of movement in kind of lung cancer and all cancers in general. Evidence is very clear that movement is beneficial along the whole cancer care continuum. So right from the prehabilitation phase into treatment, when you're going through treatment, all the way into our survivorship care or advanced care into palliative care as well. So we have like old habits. The role of movement with individuals living with and beyond cancer, we know it can help with depression, anxiety, and stress. It can help with quality of life and physical functioning, making sure that we're maintaining our activities of daily living as we're going through treatment. It can help with sleep, side effects of treatment, and then as well, cancer-related fatigue. I will take a moment to talk a little bit about cancer-related fatigue, because it is one of these things that's very hard to articulate when you're going through cancer treatments with your oncology care providers. But it is a very prevalent, prevalent aspect of cancer care. And one of the things that seems kind of like counterintuitive whenever I talk to participants or patients about this, it seems kind of counterintuitive that something that would take energy, like exercise, it takes energy to do, it will give you energy in the end. So we talk about these kind of thermometers of energy and fatigue, and the exercise and physical activity can really help fill up your thermometer to allow you to maintain what's important to you. So kind of go through the 3 Ps of looking at your days and what's important to you, kind of looking at the prioritizing what is important to you. So if you really want to spend time with your family and friends, looking at when that cancer-related fatigue is setting in and setting that time with your family and friends around that as well, and planning for that. So one thing that I always joke about with our Excel program that I used to run, we used to have exercise programs kind of throughout the day. So our early morning risers would come at like 9 a.m. Some of our retired folks might come around 1 p.m. And then we'd have our afternoon class that would be more around like 5, 6 p.m. for our working folks, for lack of a better term. And having those kind of those different types of programs for the day can really help people be able to prioritize what's important to them throughout the day, and then also be able to go to those exercise classes and be part of a group in those settings there as well. The cancer and exercise guidelines, we recommend 90 minutes of moderate to vigorous physical activity a week, which is a lot. And I hate using guidelines, to be completely honest, because any movement is good movement. 90, 90. Sorry, I know it's on Robin. She's very good at saying 90 and then 90. And I was like, I need to get better at that. 90 minutes of moderate to vigorous physical activity a week, with 1 to 2 days a week of strength training and then flexibility training on most days. So the big thing that I dislike about physical activity guidelines is that you think you need to meet that 90 minutes. That is yes, that's kind of where we put out there, but any movement is good movement. If you're currently at 10 minutes a day and you increase that to 15 minutes a day, that is important stuff. I always kind of joke when I'm talking with participants, before my grandfather passed, he had kidney failure, and I would do with him, I was very big into the functional exercises there, that every time he sat down, he would do 5 squats, just to help so that he could continue to get off the toilet seat as he aged and stuff like that as well. So it's those kind of little exercise snacks, we call them, that can also be really important there as well. And as well, that functional movement and that strength training there too. There we go, that's gonna be better. The big thing to understand is that movement does not interfere with treatment. It will help you along your treatment path. We've seen that in the literature very time and time again. There's actually even new literature coming out about people that are going through IV chemotherapy that will walk as they're doing their IV chemo or on a recumbent bike, and how that can help speed up the process and kind of help that movement there as well. So really cool, interesting literature coming out about that too. So it is safe and feasible during treatment. It is safe and feasible after treatment, and helps with that recovery and that fitness there as well. And it can also help within that palliation phase and that quality of life, maintaining that physical functioning there as well. And then it's really important too that it is individualized and tailored to what works for you. That kind of leads me into our Breathe Well program, which is boosting recovery and activity through early wellness. I cannot take credit for the name or the art. One of our undergrad students helped with that. I'm not the most creative person in the room, But what it is an 8-week prehabilitation program for people living with lung and esophageal cancer. So somebody gets diagnosed with lung or esophageal cancer. They typically see Dr. Wallace, and then she'll bring up kind of the Breathe Well program there. They typically have anywhere from 2, sometimes upwards of 6 weeks before surgery, depending on lung or esophageal cancer. And then I get the referral, I give them a call, and we take them through this individualized program. It can really help not only make sure that they tolerate treatment well, but then also we follow them after. So we have 2 weeks before and then 6 weeks after that we're going to continue to work with them about kind of making movement part of their daily life. We go through movement, we talk about nutrition, going through kind of Canadian food guide, nutrition guide, food guide there, some sleep hygiene aspect, smoking cessation, mindfulness, and that whole aspect there as well. And really working with them to understand what their treatment is and kind of going through what the next steps will be, because that can be a very overwhelming time, some of you may know, in your life there as well. So a couple key things that I want to kind of hit on the head here is to not be afraid of movement. Movement is here to help you in any way. I know it can be very intimidating if you don't, like, I'm very fortunate that I come from a physical activity background. I love physical activity. I've been physical activity my whole life, but not many people come from that background. It's never too late to start as well. You don't need to be an old varsity athlete or an ex-athlete to be able to continue to be physically active later on in your years. That goes into my next point. There are resources in your community to help you. So kind of like we said before, the Excel program. Shout out Stephen. Stephen was part of the Excel program. And there are resources in your community to help you start that physical activity journey wherever it may be as well. So you can contact me, or I can also give information out after. That this is a pan-Canadian study. So even if you're not in the prehab phase, but if you're later in treatment phase or that palliation phase, or even 5 years post treatment, you can still be part of that program. It's a 12-week exercise program to kind of help you get started in a group setting there as well. So people going through very similar aspects to you. You can control this bus. This is one thing that a patient once said to me, and it really kind of stuck with me, for lack of a better term, is that a lot of times we're going through treatment, there's so many things coming at you, you're just going through kind of the fog of what is life right now. And he said, he's like, this is a bus that I can control. It's something that I can hold in my hand, and I know that I have control over this, being that movement and exercise aspect there too. So something that I think really kind of resonates. It's not it's medical side of care, but it's more of a kind of supportive service that can really help you there as well. And then the big thing is any movement is good movement. Whether that be walking to your mailbox and back, or whether it be participating in something like the Excel program. It's never too late to start. Any movement is good movement. Those are kind of the really big 2 takeaways that I would suggest there. I'm happy to take any questions. And that's my email if you are interested in any of the Excel studies or anything there as well. And then as well, a little plug, because I'm currently just in the final phase of my dissertation. If you are keen to be interviewed about your experience of physical activity in your cancer care journey, email me. And just not so yeah. So that's it. That's it. There we go. Thank you.
I'm sorry, Lacey. Your bio did not get printed on my paper for some reason. But I'd like to introduce Lacey Sutherland. Lacey has a background in health promotion and is the programs manager at LungNSPEI, Nova Scotia PEI, and she enjoys creating programs to support Nova Scotians and Islanders with lung disease, and has been on the team for almost 5 years.
Okay, am I doing this right? Okay, perfect. Yeah, so thank you so much for inviting me today. I'm really excited to chat about some of the work we're doing around lung cancer. Super brief who we are. We are a leading health charity in Atlantic Canada. And we're really dedicated to improving quality of life by preventing and managing lung disease through advocacy, patient services, education, and research. So just want to quickly chat about some of the things that we're doing today. That is not, what am I doing wrong? I see it on here, but not on here. Oh no. What am I doing crazy? Yeah. No, okay, I'm just like crazy. Okay, perfect. My bad. Yeah, so I was really excited to see that we already had a lot of radon discussion today. So super quick is already been kind of chatted about. Long-term exposure to high levels of radon is the second leading cause of lung cancer in Canada, and Nova Scotia and PEI have high levels. So Nova Scotia 1 in 3, PEI is estimated to have 1 in 5. So we've been doing a lot of programming and raising awareness to get people to test their homes and mitigate their homes as well to protect themselves. So I just wanted to chat really briefly about what we've been doing. I'm going to kind of go down to the bottom and then I guess work my way up. So back in 2017, we launched the Radon Detector Library Loan Program. So that was really an awareness program where you could loan out a short-term test and just get some material to learn more about radon. Now there's over 300 kits in circulation, and it launched and expanded to PEI in 2019, and now it's pretty much in almost all provinces across Canada. So that's really just a screening awareness program. I then did a spin on that, and we created an MLA radon program. So to create more community access sites, but also to get our government officials to learn more about radon as well. So there's over 30 MLAs participating in this program in Nova Scotia, and we expanded to PEI too. But probably my favorite program that I have in radon right now is my radon reduction grant program. So as it was discussed earlier, equitable access and trying to reduce the cost around radon testing and mitigation is really a priority for us. So radon testing in general is around $50 to $70. So it doesn't break the bank for a lot of people, but some people that isn't a affordable expense, right? Cost of living is high these days. So we created a two-pronged program. So we have free radon test kits for Nova Scotia households whose income is less than $60,000. You can apply on our website, or you can give us a call if you don't have access to the internet, and we can sign you up and we'll send you a free test kit. My other prong of the program is my radon mitigation assistance grant. So radon mitigation ranges $1,600 to $2,500 for a uncomplicated standard mitigation. That's a lot of money, right? So this is a barrier. So there's a barrier to testing because a lot of people, if you know you can't afford that mitigation, well, you just rather live in that unknown, right? Than knowing you have this bomb in your house, right? That's a concern. So we created this mitigation grant. So we offer up to $2,500 for Nova Scotian households who have high levels of radon, whose household income is $100,000 or less. So we're so excited and thrilled to have this program running to reduce barriers to mitigation. So we've been running that since May of 2024, and in January of this year, we had went from 80,000 up to 100,000 to just create that little more accessibility now. So we're super excited about that. And we're really grateful that that program is funded by the government of Nova Scotia. So they really do recognize that radon's an issue in Nova Scotia. A few of the other things that we're doing, we host the Art for Lungs event, which is actually upcoming in May. So it's a networking and educational event that's hosted by LungNSPEI and in partnership with the Division of Thoracic Surgery. Alison is on that steering committee. Some of the event goals is raising awareness for local lung cancer outcomes, highlighting groundbreaking research, innovative projects that's happening here, and just exploring the patient journey as well. And also some of the funds raised from this event go directly to support local lung cancer research as well as advocacy work. Just jumping on, this has been chatted about on and on again today, so this is super exciting. But LungNSPEI is also a member of the steering committee. Our CEO, Robert McDonald, does sit on the steering committee for Nova Scotia, and as he asked me to mention today, the expansion, so that's exciting to hear about. And then for PEI, they recently did announce that they will be doing a lung screening program as well. So we were advocating heavily for that for many, many years. So just see like the actual commitment is great. and we will continue to stay in discussions with the PEI government as well. And then we also do a lung cancer stigma campaign. So it's a digital campaign that we've been running since 2021. So we really just want to reduce the stigma that everyone deserves the same level of treatment, compassion, and that anyone with lungs can get lung cancer, right? So we just want to kind of keep that messaging out there and continuing. Yeah, so it was launched in 2021. We've had over 1 million impressions, online impressions since it's launched since then. So that's really exciting to hear that, you know, we are reaching people with this messaging. And we're going to be doing a spring campaign, as well as we always do one in November during Lung Cancer Awareness Month as well. And then finally, what we're always doing, regardless of any lung disease, but including lung cancer, is collecting patient stories. So when we talk to patients, family members, caregivers, loved ones, these stories help us to, you know, support reducing stigma, you know, that awareness that others are not alone in their journey, as well as strengthen our advocacy voice, right? So you all know what is needed, and then we can help be that voice to help create that change, right? So having that understanding of what is needed can really shape our direction for our advocacy work. You know, it's always our challenge for us to collect stories. So anytime anyone wants to chat, we love to do so. And then finally, just super quickly touching base on some of our smoking cessation work. So we are going to be launching, hopefully sometime this year, Your Way project. So it's a tobacco cessation program that will be delivered at the grassroots level. So this was developed out of our community advised cessation program. So we actually worked with communities to really understand what individuals need and want out of a smoking cessation project that's going to meet their needs in their community, where they live, work, and play at, right? So we are taking all that information and actually going to implement a new cessation program as well. And short and sweet, that is all I have today. Thank you.
Yeah, thank you so much, Lacey. And it's so great to hear about all of your advocacy efforts and efforts to support patients. Just to touch a little bit about ours, I know we have about 5 minutes left. We ended up on time. Look at that. We have our comprehensive guide to lung cancer, which is new. And new to our website is a newly diagnosed page. So it has all of our support programs, what you might initially need when you're first diagnosed, all on one page. So if you're in contact with anyone that you're diagnosing and newly diagnosed, there are postcards at the front. We're going to send more out, but if those of you who are involved with patients, if you could take some and hand them out, that would be great. We offer online support groups, one-to-one support with a social worker and with staff for navigating the system, for psychosocial help. We also run a peer-to-peer program, which will match patients based on their diagnosis and treatment so that they can support each other. Do you want to come up and talk about, or you have?
Yes.
I will invite Ramsey up to talk about.
Yes, I am the events planner for Give a Breath, and it's so exciting. Halifax is hosting it for the 2nd year. Give a Breath's been around since 2019. It started in Edmonton, and it has grown and grown and grown. In 2023, there were 3 cities. 2024, there were 4 cities with Halifax. And now this year, there are 6 cities across Canada. So it's really exciting. It's super fun. We had a great time last year, and hopefully you'll join us. If you do want to join us, don't be daunted by the 5K part. You can walk however much. No one is checking in on you. We are just going to check in that you're having a good time. That is all we're going to check in on. It starts at 10 o'clock, so we're going to open up the sign-in process at 9:15 or so. And if you do want to register and create a fundraising profile and fundraise for Give a Breath, you just need to go to www.giveabreath.ca. And the funds go to two places really. So one of them, it goes to Airways of Hope. So 50% of all of the funds go to Airways of Hope, so all of the support programs for Lung Cancer Canada, and the other 50% of the funds that we raise go to the new Give a Breath Research Award, and that just opened up in November. We will be announcing the recipients of the awards, the first award, very, very soon. So that's really, really exciting. So please join us June 7th. It's awesome. Shuby Park is great, and hopefully it's going to be nice and warm this year.
I know I'll be there in Toronto, but I'm sure you guys will have better. Well, it's beautiful in Toronto too. I just want to thank everybody again for being here, and I hope you learned a lot, and I hope you met each other and formed bonds, and thanks again.
Thank you.